Okay, well, it's 9:33, so I'm going to start to kick this off as people are still joining. So welcome everyone to our HIV Center Grand Rounds. Let me start by just acknowledging, and with a very heavy heart and sadness that, profound sadness that many of us are experiencing with two very significant losses recently, starting with our co-founder founding co-director of our center, Zena Stain, a real luminary in the field and a tremendous loss to many of us. And then most recently, just this morning, we lost a dear friend and colleague to our center, Scott Hammer, who is former director of Division of Infectious Disease here at Columbia University Medicine. And these are very, very significant, profound losses. Like I said, luminaries in the field. So many of us are mourning those two losses. And I just want to acknowledge it here. I can't say more to tell you personally because I would not be able to do that emotionally. But please go to our website, look to our website. We'll be posting descriptions and acknowledgements of both of these esteemed colleagues of our HIV Center. So just wanted to say that. In terms of our remaining rounds for this calendar year in December, let me announce what we have in December. On December 2nd, we have Avram Finkelstein talking about AIDS and the dilemma of the 21st century image. And then on December 16th, will be two of our former postdoctoral fellows. We have Rita Melendez. Title is Using Research Recruitment Strategies as a Guide for Expanding Services to Latino Immigrants, Lessons from 20 Years of HIV Research. And David Knapp Whittier, his talk is More Than a Pill, Articulation and Implementation of HIV PrEP as a System in US Public Health. So please join us for that before the late December holiday break, and then we'll be in the new year. So let me move on to today, and we're very privileged to have with us yet another distinguished leader and luminary in the field, a long-term colleague for many of us. So we're so pleased to have Dr. David Holgrave with us. David Holgrave is serving as the Dean of the School of Public Health, University at Albany, State University of New York, SUNY Albany. David, my undergraduate alma mater. He's also appointed as a SUNY Empire Innovation Professor and a SUNY Distinguished Professor. He did most before he came to New York, to Albany, from 2005 to 2018. He was professor and chair of the Department of Health, Behavior, and Society at Johns Hopkins Bloomberg School of Public Health. And in July 2017, he was appointed to hold the inaugural Health, Behavior, and Society Professorship, which is an endowed professorship, and held joint appointments in the Johns Hopkins School of Medicine and Nursing. I think we all know David for his extensive work in the field of HIV prevention since 1990, 1991. His research has focused on the effectiveness and cost effectiveness of HIV prevention interventions, the translation of those study findings to HIV prevention policy. Dr. Holgrave previously served as a member and then vice chair of the Presidential Advisory Council on HIV/AIDS during President Obama's administration and testified before the U.S. House of Representatives during Henry Waxman's hearing on domestic HIV prevention in 2008. So you can see his tremendous influence in the field. And then just bringing it a little bit closer to home, Dr. Holgrave, David has become heavily involved more recently in partnerships on projects with the New York State Department of Health to address a number of public health challenges related to COVID-19. This work includes projects that lead to pioneering publications on COVID-19 epidemiology, treatment approaches, prevention, and addressing of health disparities. So again, thank you, David, for being here. Very important. And we really look forward to your talk today. Turn it over to you.
Thank you so much, Bob. Thank you for that very kind and warm introduction. And thanks to you and Theo and Stephen for the great invitation to be part of this conversation today. And I just wanted to also echo your comments. The loss of Zena and Scott are just tremendous losses. And There were such amazing colleagues and wonderful leaders in the field. And I know for all of us, their memory is most certainly a blessing. And I hope we can dedicate this conversation today to their memory. Also, I just wanted to say thank you to all of you who've made time to be part of this conversation today. We've got a great turnout, and I see a number of colleagues, Joanne and Kathy and John and others who I've had the privilege of working with over the years. So great to meet some new colleagues and to virtually see or participate in this discussion with longstanding colleagues as well. So thank you all for making the time today. And I'll pull up my slides here and see if I can share these. There we go. See if that works. Great. It looks to me like they're probably being shared on your end. If you have any trouble seeing them, just please let me know.
Looks good, David. Thanks.
Excellent. Thank you, Bob. Good. So I thought what I would do in the next 50 minutes or so, and to make sure we save a good half hour for discussion, is to very briefly talk a little bit about our work at UAlbany in COVID. I've had the privilege of working with a number of you over the years, and I know that you know a lot of our HIV-related work, our collaborative center with the New York State Department of Health and some other colleagues. But I thought I would share briefly what we've done in COVID, because as Theo and I talked about what we should cover today, it seemed that it was useful as you're thinking about your center grant renewal next summer to think about how has COVID informed HIV, how is HIV informing COVID, and how synergistically can we bring these areas together to inform each other. So I crafted this very much in the spirit of kind of a brainstorming of thinking about that intersection between HIV and COVID-19 and how one informs the other and sort of goes back and forth here. So first, again, I'll say just a word or two about our COVID work, then talk a little bit about a trio of editorials that we did in 2020, kind of pulling lessons from HIV to trying to inform the COVID space. Then talk a bit about how we tried to reinvent kind of the HIV care continuum in COVID as a kind of COVID outcomes continuum and how that helped us look at health disparity issues in COVID. Some writing that we did looking at the National HIV Strategy from 2010 and 2015 to try and inform what a national COVID strategy might look like. And then again, toward the end, really just brainstorming 3 other areas that I'll name later as other possible synergistic areas of how these two spaces, COVID and HIV, might potentially inform each other. So again, just a few slides on our COVID work at UAlbany, just to give you a sense of the lens that I'm bringing to this on the COVID side. We did quite a lot of work in partnership with the New York State Department of Health. First, just initial response issues, just trying to do whatever needed to be done. And I know this was also true at Columbia for sure. So much great work around COVID came out of Columbia as well. The second was kind of a phase looking at epidemiology and tracking. Third, sort of crisis response. How can we do whatever is necessary? Related to that, also some media work. We did a lot of local, state, and national media to try and help inform the public around issues on COVID. And then the third big area is kind of reopening guidance as the university and other organizations in society reopen. What can we offer to that? And then also thinking about kind of a way forward. So in the earliest days of COVID, some of the first work we did with New York State Department of Health was they asked us if we could very quickly try and do a study on whether or not hydroxychloroquine was useful as a treatment for COVID-19 or not. So actually in a few weeks' time, we did a study that was published very quickly in JAMA and did not find benefits of hydroxychloroquine with or without azithromycin. Also, the state was really interested in what we could do on multi-system inflammatory syndrome in children. And we collaborated with them on one of the first papers that kind of set out the symptoms and the constellation of what multisystem inflammatory syndrome really looked like in children and what the consequences of that were and some of the early epidemiology there. In terms of tracking the epidemic, some of the work that we did looked at trying to use some of the early antibody serosurvey work to estimate how many people, this was as of kind of late spring, early summer 2020 in New York, might have contracted SARS-CoV-2 and made some estimate of that. At that point, about 2 million people in New York probably had contracted SARS-CoV-2. And then also we wanted to understand how it was moving through New York. So we did one paper that was kind of an early history of what went on in the state, testing risk factors for acquiring COVID transmission and various outcomes. And then we, as I said before, we tried to do media whenever asked, from locally to nationally to globally, to try and share some of these lessons wherever we could, because so much in response to COVID was sharing all of our collective science as quickly and as soundly as we could. And these are just a couple of the things we did with CNN. And then the middle slide here is on the right-hand side is Eli Rosenberg, one of our faculty who now is full-time at the state, who was on a number of advisory panels for the state around COVID. So this translation was key, we thought, to devote effort to. Next, here at the university, we got involved a lot in helping to be a partner with the RNA Institute, develop a pooled testing program, a saliva testing program, standing up testing clinics, helping to support vaccine clinics. And then also Tomoko Udo on the faculty was very instrumental in supporting a student support team that focused on mental health services here at the university. And then a number of faculty, including Erica Martin in their class, had sort of online experiential learning on things like developing real program evaluation plans of a contact tracing program as part of their coursework. So lots of involvement in different ways. And true to for community engagement, we had a lot of faculty. This is Gus Burkhead, who many of you know, is a member of the faculty here, used to be at New York State as a deputy commissioner for many years and at the AIDS Institute, and many of you know Gus. Gus alone and many of our other colleagues vaccinated many people and were involved in a lot of testing programs and vaccination clinics as well. Also, the students, besides the coursework I mentioned before, I was so proud of them. They really dropped everything that they were doing. They worked in emergency departments, in schools, in health departments, in non-profit organizations. They did things like contact tracing, analyses, food safety. The bottom picture on the right is a student who was very interested in food security issues and helped with local programs during the course of the pandemic. And so many students volunteered their time in so many different ways. And we were extremely proud of what they did. As far as papers, I've lost track a little bit. As of a couple of weeks ago, we had about 54 papers on COVID that we had done, including some of the things I mentioned before, but also Julia Hastings has done work in African-American faith communities and focused on mental health in Black communities. Erica Martin has done work looking at health impact that closures of schools had on children. Jen Manganiello has done work on face mask guidance from governments around the world and how it compared from country to country. So lots of different publications, and just a few areas that we've continued on. A lot of interest in how HIV, persons living with HIV, whether they were more or less significantly impacted by COVID. And we actually found that in a paper in JAMA Network Open, there did seem to be more of an impact in serious illness for persons living with HIV from COVID. And then most recently did some work that was in the MMWR looking at New York State surveillance data on COVID vaccine effectiveness and breakthrough infections. So again, I'll stop there. I just wanted to give a little bit of a flavor of some of our COVID work so that I can now kind of sort of bring things together with our HIV experiences. And again, I'll start with this trio of editorials. But before I do that, I just wanted to acknowledge that many people, including a number of you at Columbia, have talked about, discussed, written about the intersection between HIV and COVID-19. And this is just a quick collection of a few things from the literature. There are many more that we could highlight today. So I wanted to acknowledge that when I talk about some of the pieces we've written, is by no means a comprehensive overview of all of the collective wisdom about how HIV can inform COVID. This was a very early paper that I did with Ron Baldessari during the time of COVID. And almost immediately we said, there's a lot of lessons that we can learn from HIV to respond to COVID. And you can see, I won't read through everything here, but we made some really, I think, hopefully useful, but very basic points in this piece. Things like sustaining investment in public health infrastructure. We weren't seeing much involvement of the social and behavioral sciences. Both are needed, the biomedical sciences as well as social and behavioral sciences. There needed to be engagement of communities. We didn't see that as much early on as we thought was really critically important. And also, we thought it was really key to focus on health equity. And at that moment, there had not been a lot of focus on disparities and health equity. Also, Ron and I and Gary West, who some of you may remember from CDC, did a piece on COVID-19 testing and what lessons we can learn from the HIV testing experience. And just a couple of points here. One is, many of you know who've worked in HIV for so long, early on, there was really a lot more emphasis on making a choice available between anonymous and confidential testing. And we thought maybe early on in COVID that having that option, an anonymous testing route, which is kind of the home antigen test route now, might be an interesting pathway to explore. We also thought one of the keys in HIV was making testing extremely widely available, making it as available as free as possible everywhere as possible, and that this needed to be brought into the COVID space as well too. Also thinking about testing as a pathway to other needed related services, that testing didn't just end there, but was a key pathway. And also that there were issues of program evaluation, accountability, performance management that can be informed by testing data that could also supplement surveillance data. And this has certainly been true over the decades with HIV, where the HIV counseling and testing data at CDC is an important supplement to the surveillance data systems. Also, we were really interested, and this is a piece we did with Seth Kalishman, looking at some of the earlier lessons we learned about condom promotion and what that might mean in terms of mask promotion. And clearly some major differences, of course, between condom use and mask use. But as we sort of reflected on this, we thought some of the principles like collecting data to understand what did this device, whether it's a condom or a mask, what did it mean symbolically and culturally and personally to the person who was being asked to use it, and what are the attitudes toward use of the device. Also thinking about if you want to promote the use of condoms or masks, how do you use multiple channels of communication to make sure there's appropriate and accurate information? Crafting targeted interventions to promote the uptake of this behavior, and finally, monitoring the uptake of preventive behaviors in areas that are most disproportionately impacted and within geographic areas, so that we can make sure that not only do we assess the disparities in access, but also we can make sure we're actually building health equity and can monitor that over time. Another area that I think we were really interested in was how could we use the care continuum that so many of us have seen and written about and used and contributed to over the years, and whether or not that could be brought into the space of COVID-19. And we were especially interested in trying to bring in the continuum because at that particular moment, so this was a paper from end of June of 2020, there was recognition that there were tremendous racial and ethnic disparities in COVID-related fatalities. But it was that disparity was being identified, but there was not a lot of work at that particular moment, we thought, that was trying to understand what were the causes of those disparities and how could we go about trying to build health equity. So this particular paper, we did try to use data available in New York State to construct a COVID continuum going from size of population to experience with contracting COVID, SARS-CoV-2, to being diagnosed, to being hospitalized, and sadly to have transitioned from COVID-19. And we, on this slide, you see we had for non-Hispanic white communities at the top, non-Hispanic Black communities, and Hispanic communities at the bottom. And one of the things that we found, and I'll just go to this last highlight here, is if you started with the disparities in fatalities, which is kind of where things were going in the media at that particular moment, what you really miss are whether there's differences in hospitalizations, whether there's differences in diagnoses, and whether there are differences in contracting SARS-CoV-2 in the first place. And perhaps not surprisingly to those of us who worked in HIV, where we know that so much is relevant in terms of the social determinants of health, similarly true in COVID-19. A lot of the disparity that one saw in COVID-19 fatality needs to go all the way to the left side of the continuum here, to where people had differences in terms of exposure, in terms of different accesses to different kinds of services, and that we saw these disparities in differences in exposures very much on the left side of this continuum. And if we want to try and make a difference in the disparities in COVID-related fatalities, you can't wait until people are hospitalized or diagnosed. You have to start your interventions much, much earlier than that, which is certainly true as we think about HIV, but we also thought as well as COVID as well. And this is just a table version of the last figure that I showed. If we had, for white non-Hispanic, Black non-Hispanic, and Hispanic communities, a population size of say 10,000 people, how many infections, diagnoses, hospitalizations, and deaths would you expect to see? And again, by displaying it this way, we thought it made the point clear that we must intervene at all stages of the continuum, and especially as early as possible, to try and address these disparities in COVID-related fatalities. The next piece I wanted to talk about that we thought there was some connection with was the National HIV and AIDS Strategy, and how that might inform a COVID national strategy. And I know many of the people on the call today were involved in either the development or review or use of the National HIV and AIDS Strategy. So I don't have to say much about that to this particular group. But in 2020, there really wasn't a comprehensive national strategy for COVID-19. There were some elements in CDC guidance and NIH treatment guidelines, in White House task force reports for states, which were kind of closely held, and some FDA statements around drug concerns and emergency use authorizations, but not one sort of overarching plan. And what struck a group of us was that it would be really useful to take the extraordinary National HIV and AIDS Strategy, which I think in many ways is kind of an exemplar in public health for developing national strategies, and looking at the 2010 original strategy in 2015 is kind of an informative guide for thinking about how we could construct a national COVID strategy. And again, since so many of you have been involved with the national strategy, I don't have to say much other than the vision statement, I think, was so important in the HIV strategy, that the US would be a place where new infections are rare, and when they do occur, every person, regardless of age, gender, race or ethnicity, sexual orientation, gender identity, or socioeconomic circumstance will have unfettered access to high quality, life extending care free from stigma and discrimination. And I think this was such an important vision statement in 2010 when it came out. Also, this plan, the original one, had, of course, the 4 overarching areas of prevention, treatment, disparities, and coordination, had 10 quantitative metrics. There was a pretty transparent and participatory process along with annual evaluations and mid-course corrections that went into it. And I think when the president released this in July of 2010, it really brought together for the first time for HIV in one place a reasonably comprehensive plan. And before that, there were certainly pieces of plans from non-governmental organizations, from individual federal agencies, maybe individual departments or states. And there were report cards like the DC Appleseed report cards, but this was an attempt to really have one national strategy. So when we reviewed this and thought about how could this inform COVID, I worked with Seth and Ron and Carlos Del Rio and Melanie Thompson on this, and it struck us that the vision statement for COVID could be really similar to the HIV vision statement. If you kind of replace HIV with COVID, it still reads pretty well, actually, and could inform us. And then we thought in this particular piece, we kind of proposed a table of contents. We certainly couldn't write what a whole COVID strategy would look like, but we wanted to propose what that might be. And we thought a few points. One was kind of laying out the clear epidemiology of COVID-19. Secondly, having some kind of systematic framework for thinking about COVID-19. And when we did this, we really thought that using the outcome continuum that I talked about earlier could be kind of a framework for weaving everything together, much like we've seen the HIV continuum be used as an overarching framework now. Third, we thought it was important to address structural interventions and social determinants of health and social factors clearly, including things like housing instability, food insecurity, housing density, given the airborne nature of COVID, unemployment, differential employment opportunities, and so on. Fourth, we were proposing that there should be a focus on some non-pharmacologic mitigation measures like mask use, and at that time more on social distancing. Fifth, a focus on biomedical tools that could be used, vaccines, monoclonal antibodies, and other prophylactic interventions. Sixth, ensuring access to early diagnosis and prompt contact tracing, and try to sort of make the point that when we, in HIV, things evolved certainly over the years from partner notification to contact tracing to partner counseling and referral services, and to take that more comprehensive view of relationship building that's a part of partner counseling and referral services. Seventh, thinking about optimizing treatment for acute infection and looking at long-term consequences is really key, of course, in COVID. Eighth, focusing on disparities, identifying the disparities, but then also figuring out how do we build health equity, and whether that means addressing things that are COVID specific or social root cause issues like economic instability, income inequity, inequality in educational opportunities, systemic racism in health, housing, transportation, and other social services, all critically important. Ninth, we thought it was important to consider mental health and preventing and treating substance use and addressing stigma in a pandemic era, all very much related. And now we've just seen this year, sadly, crossing 100,000 opioid overdose deaths for the last year. That was just new data released yesterday. 10th, rebuilding an under-resourced and outdated public health infrastructure overall. 11th, having aggressive goals and then measurable metrics and the resources needed to meet those goals. 12th, making sure that we understand all different levels of contributions, individual, organizational, community, and governmental, to achieving the goals, all aspects of society needing to come together in some way. 13th, case studies so that we understand the narratives from cities, rural areas, states, indigenous nations, and global partners. How was COVID-19 playing out? How could it be addressed? What does the qualitative narrative sound like? And 14th, a more modernized communication strategy for infectious disease outbreaks in the US and around the globe. And then finally, the evidence base for anything that's recommended. And we also thought it was really important to make sure there were measurable metrics, aggressive goals, evaluative strategies, and methods for mid-course corrections, and also to try and be as comprehensive as possible and make this a living document. And this slide, all I've really done here is take the HIV strategy and kind of put in COVID or SARS-CoV-2 where HIV would have been previously. And as I said before, I think the vision works pretty well. The HIV strategy, I think, was quite pioneering in setting ways of thinking about an overarching vision to tackle key public health challenges. And maybe this works pretty well for COVID too. So, where are we at now? That was in 2020. The Biden administration has their plan, the path out of the pandemic. I think it has a lot of the elements that we were just talking about in it, a lot of the important pieces. And then included here, but also separately, there's a brand new report out on from the COVID Health Equity Task Force, which is really critically important too for taking a very detailed look at how to address health disparities and build equity in COVID. One thing I would say is I think that the next step would be to evolve this plan for the current administration to have even more in the way of specific goals over time. And build them in a way that kind of reflects the focus on health equity that was in the National HIV and AIDS Strategy. And what I mean by that is certainly there have been goals like getting 100 million people vaccinated by the 4th of July this past year and so on. But this could be populated even further with specific goals and metrics like we see in the National HIV and AIDS Strategy. So this is another area, I think, of synergy between the areas of COVID and HIV. So then just in these next maybe 15 minutes, and then I'll stop with my monologue and turn it to the better part, which is a discussion and getting your comments, questions, and suggestions here. I thought maybe for the purposes today, I would venture into a little brainstorming in 3 other areas as well. One is the area of translational research, implementation science, advocacy, and knowledge brokering. Secondly, focusing a bit on disease elimination and eradication principles. These are sort of very old school bedrock principles of public health that go back with some really foundational writings on this from CDC days. And I thought they have, these principles have something to say, both I think for HIV and for COVID-19. And then also ending just briefly thinking about loss, trauma, grief, remembrance, and inspiration in HIV and in COVID space as well. So I have a few slides on each of these 3 points, and I'll just walk through these. I think on the first point of advocacy and translational science and implementation science, it's really important to acknowledge some of the very important work by ACT UP, by the Treatment Action Group that a number of you have been involved with, and that a number of activists have written about and have become part of the literature on how we respond to such incredibly challenging public health crises like HIV by using the best available data and insisting on that data be generated and that it be utilized in a meaningful way. And certainly ACT UP and the Treatment Action Group were really key parts to this. So I wanted to acknowledge that advocacy, I think, is really very critical in what we're talking about with translation. Also, this is just one page from a paper I did after I left CDC. I was there in the 1990s and very early 2000s. Is that a lot of what we tried to do in the HIV prevention division was make sure that the reality of the field, the health departments and community-based organizations that were funding, that their reality was informing an applied research agenda, and that applied research agenda was answering questions that were actionable in terms of program and policy, and that could be translated back into the field, and that we utilize techniques like research syntheses, like cost and cost effectiveness analyses, and so on, that can help with that dialogue between program managers, policymakers, and researchers generating information, and very much thought of this as bidirectional arrows everywhere. It's not just the kind of, sometimes I think when we think of translational work, we think of a unidirectional arrow going from what's our study say, what does the journal article say, to we'll translate that somehow into the field, but that this is an ongoing dialogue and it's very much bidirectional. And I say that bidirectionality is really key because, when I was at CDC, this is just a picture of the first compendium from 1999, where we summarized every HIV prevention intervention we could find. A number of you were co-authors on these prevention interventions that were summarized in this compendium. And I think first with the thought that if we put this together, it will increase utilization in the field. That was true to a certain degree, but you need to have this ongoing dialogue to really better have uptake of these interventions. Also, I think the field of implementation science now has continued to move on and say that it's not just this sort of left to right science to program and policy, but there's a wide variety of contextual factors that you have to consider when we're talking about adapting interventions. Things like, is the system actually ready to use this intervention? Can we just use it exactly as it stands, or do we need to adapt it in some way for it to be able to be used? And what's the social and political and economic consequence or context rather that surrounds all of this, and how can we take all of these factors into effect if we're thinking about the translation of science into program and to continue to foster this this dialogue. In this framework, this hexagon model from Blaze and Kaiser and Van Dyke and others, and it's from the National Implementation Research Network website at UNC. I've always been really struck by this because I think it brings together in this really nice way that if you want to try and implement an evidence-based intervention, we have to think about what's the need for that intervention. Does it fit with community and local needs? Are there resources to be able to do it? Is the evidence relevant, and is it sound enough? Is there readiness in the community to receive this intervention, and are the systems ready to implement them? And is everything available to do this at capacity? Are the resources there to be able to implement it and to sustain it over time? And I sort of really like this hexagon model because it's just one way of kind of thinking about when we're translating evidence into program and policy, are we taking into account all of these factors, which are really critical considerations as well too. And always when I talk a little bit about implementation, I have to include this one slide. Bill Faggy was at, who many of you know, of course, was at Hopkins one time in 2012 to give a talk. And one person got up and asked him, should researchers advocate? And Dr. Faggy immediately said yes, and that was it, just yes, period. And then the person followed up and said, well, how far should they go, and where's the line? And Bill Faggy said, the line is the truth. And I've always really liked that. He was very much in favor of researchers advocating for sound public health programs and policies, but that they should be informed by what is the evidence base and sort of use that as kind of their swim lanes, if you will. So I thought it was really interesting comment from Dr. Faggy. Also, I just wanted to say on this issue of implementation, there's this area that I'm learning more about called knowledge brokering. And this was a paper in Science in 2012 about emerging professions. And this one is called knowledge brokering. And by knowledge brokering, what seems to be meant is that you have people whose job it is to sort of facilitate that bidirectional dialogue we've been talking about, trying to make sure that there's listening to the field, that the evidence is being packaged in a way and in a time and in a format that it can inform program and policy, and that dialogue actually takes effort and takes support, and that there's this sort of emerging area called knowledge brokering that helps to do that. And I have to say, I got a chance to learn much more about this from a student who now is a faculty member at Witwatersrand in South Africa and also at Hopkins. And her dissertation, and I was lucky to be on her dissertation committee, was really focused on, in Kenya, all the schools of public health. There were 12 or 13 schools of public health in Kenya. And she interviewed all of the faculty members and talked about whether their work was being translated outside into program and policy, and then talked to a number of the key public health figures in Kenya to see whether those connections were really meaningful. And it was striking to me that she was really trying to look at this issue of social capital, human capital, and how academic institutions and policymakers were working together. And not just that it was a desirable thing that this occurred, but rather she was making this an area of empirical study to look at it, how it occurred. And it's really informed, I think, a lot of our subsequent thinking. I've had the good fortune of now doing a number of papers with Dr. Gisani, that we took her dissertation and then redid the same thing at Hopkins, interviewing a number of faculty members and then policymakers with whom they interacted at the local, state, national, and global level to help try and empirically understand this translational and bidirectional dialogue process. The other thing it informed for us, this is some work with Kathy Malsby and Kriti Jain and a number of other people, Vignetta Charles and other colleagues from AIDS United, where we tried to look at in HIV, if you were to intervene, not with the individual, but you wanted to change the whole system, you wanted to change that whole care continuum, how could you intervene on things like developing better systems for clients to navigate to be able to get an array of services? And so in a number of areas, AIDS United supported positive charge interventions, the purpose of which was to create denser, richer, easier to navigate networks for clients to get a variety of different services. And this is just from Louisiana, a number of service providers before positive charge, a social network diagram, and how they were connected with each other. And then the intervention, this is, again, I'm just using the Louisiana example. The intervention was things like building stronger case management systems. Many of you heard of ARTIS before, using patient navigators and health educators to help people maneuver hospitals and healthcare systems, a post-release case manager for persons who were previously incarcerated, and community-based peer navigators to help maneuver through outpatient care. And after that intervention, this is what the social network looked like among care providers, a much richer, denser network and an easier pathway for people to get a variety of services. So I bring all of this up just to say, I think when we're talking about how COVID and HIV can inform each other, some of the lessons we've been learning in HIV and related spaces about implementation science, translational science, knowledge brokering, and advocacy might have interesting ideas for thinking about COVID and other areas. So the second of these 3 points, and again, then I'll stop, is disease elimination and eradication principles. And This goes all the way back to and before work by Walt Dowdle and other people at CDC. I remember being at a whole conference on disease elimination and eradication and what that meant, along with terms like control of diseases. This goes back to the 1990s and even before that. And I think the main thing that I took from this is, of course, everyone on this call has heard these terms before and knows that if you're eradicating something, you're kind of wiping it off the face of the earth. And that's a very difficult thing to contemplate being able to do for HIV or to COVID. But if you one key principle, though, I think from those discussions of disease control, elimination, and eradication was if you're going to make key progress in some areas, you have to be able to identify what your goal line is, and then you accelerate through that goal line. You don't try and coast into the goal line. And this was a piece that we did in the Hill, where at this time, so this was March 28th, of 2021. A lot of discussion by the Biden administration then about opening up the country for 4th of July picnics for relatively small groups of people. And what the point we wanted to make was, if you were really going to do that, you really have to think about these issues of disease elimination and eradication, and how do you keep accelerating through the finish line? So our point was, don't coast into the 4th of July of 2021. Set really aggressive goals like getting mask use up to 90%, push vaccine policies in states that were just kind of, in some instances, kind of giving up on their COVID strategies. Don't go backwards, continue those policies, push for major uptake of vaccinations, making sure that you had persons who were living with COVID have access to monoclonal antibody or other treatments that might be relevant and available. And then set a goal of something like, and it's hard to know what the ideal goal is. Of course, you'd like it to be 0, of course, deaths per day, but influenza across years, across days, across seasons, on average, influenza is about 50 to 100 flu deaths per day in the United States. And so we said as an interim goal, maybe that would be a place to try and get to by the 4th of July, try and get to no more than 50 COVID deaths per day. And of course, we're still at roughly 1,000 COVID deaths per day now. And then, of course, to be able to eliminate health disparities. And even though these seem like a really aggressive set of things to do, our main point was, if we're going to use bedrock public health foundational principles, if you want to try and really get to a place that you could sort of open up by the 4th of July, you have to really hit hard in all of these different areas. And of course, it didn't quite play out that way. So this is older guidance from CDC about, on one side is persons who are unvaccinated, and the other side persons who are vaccinated. And I know everybody on this call has seen this figure before. If these little figures had masks on or not, or whether you should wear a mask. And first, CDC said if you were fully vaccinated, it could alleviate some of the mask wearing, but not too much. And then the red, yellow, and green was sort of background of how safe or not safe different behaviors were. And then in May 13th of 2021, CDC said, well, if you're vaccinated, fully vaccinated, you can essentially remove your mask, indoor and outdoor. And they were attempting to use mask use as an incentive to be vaccinated. And immediately, literally within hours, Eli Rosenberg and I wrote a piece, and it was published the next day in CNN Opinion, saying we were concerned about that. We thought that there were a number of issues, and we said, we were fully vaccinated at that point, but we were going to keep wearing our masks for a while for a few reasons. One, we thought it was important to fully inform the public on what are very low, thankfully very low levels of breakthrough infections, but they're not 0. And if they're non-zero, there should just be an accurate description of how frequent they do or don't occur. Secondly, that even if you're fully vaccinated, you might choose to wear a mask for a little bit longer time. We were saying, until there was a higher level of uptake of vaccination, until deaths were down to something that looked more like influenza, and so on, we thought it made sense to continue to wear a mask. We also thought there needed to be a more detailed plan put out for encouraging vaccination, more of a plan for businesses and others to be able to tell who is and who isn't vaccinated, a need to be able to tie relaxation of precaution to public health goals, not just to each other, and also a need to really accelerate across the finish line. So then in July 27th of 2021, CDC changed this and went back a little bit closer to the original guidance, but not all the way. After Delta variant came along in COVID, then CDC said, well, even fully vaccinated people should maybe wear a mask in indoor public settings in areas of substantial or high community transmission. And actually, at that point, not every county in the US was substantial or high, but it didn't take long after that for essentially everywhere in the US, not quite, but essentially everywhere at the county level to be experiencing what CDC defined as substantial or high levels of transmission. So they moved much further back in terms of using a constellation of preventive measures like vaccines and mask use together in synergy. So it took a little bit, but CDC made this adjustment, which we thought was useful. And then the last couple of slides I will just show, and sadly we're kind of ending at a place similar to where we began today and thinking about loss, trauma, grief, remembrance, and inspiration. And during the talk today, I mentioned that we just now saw data from CDC yesterday of estimated over 100,000 opioid overdose deaths over the last year. We know from all of our collective experiences, all of the loss that's been experienced in HIV space. And of course, here, there's so many ways to remember everyone who's been lost to HIV over the decades. Here's just one picture of the quilt on the National Mall. And I think some of these ways of communicating that were used in the HIV epidemic are really important to think about for COVID as well, too. And in some ways, a really critical kind of lesson. In HIV, over the years, the quilt was such a way to grieve and to mourn the loss of people by the assemblage of the panels of the quilt, but also showed people the magnitude of the loss and can communicate to the public even more generally the substantial magnitude of the loss. And also, as I know everyone on this call has done, as you look at the panels and read and take in the panels, so many of the narratives and stories are so important. And there's one panel I always remember from Sandy Thurman's office when she was the director of the Office of National AIDS Policy in the White House and on Jackson Square. And the person who had passed from HIV had asked that their ashes be sewn into the panel. And the panel said not to release their ashes, not to cut their ashes out of the panel until there was a cure for HIV. And when we talk about cure on HIV, all these many years later, even though we get closer and closer and kind of with the treatments, we have in many ways taken many steps toward a functional cure, but we don't still have the ultimate cure. I still think about that person's ashes in that panel somewhere, wherever it's being held. All these decades later, that's probably 30 years or so since I saw that particular panel in Sandy's office. So I just use this one picture of the quilt on the National Mall to say there's so many ways that people have expressed loss, how they've dealt with grief, with mourning, and with inspiration and remembrance in HIV space. And I think this is really true and important in COVID as well. The closest to the AIDS quilt has been on the National Mall when there were about 600,000 deaths. Now, of course, we're passing 750,000. deaths, and the number of people lost to COVID, of course, is about equal now to the number in the US is about equal to the number of people lost to HIV in the US. These small white flags were put on the National Mall, hundreds of thousands, and that people could start to sort of put names and remembrances on the individual flags. And I just wanted to show that and end that, because I think we talked a lot about epidemiology and quantitative analysis and implementation science and so on today, which I think are incredibly important. But at the end of the day, it's really about how we confront the loss, the social injustice of the disparities that have been seen in HIV and in COVID, and how we can learn all of the lessons about loss and resiliency and remembrance and inspiration, so that on both of these fronts and in many others, we can continue to make a difference and make an even bigger and better difference, so that we can stop adding panels to the quilt, we can stop adding flags to these memorials. So let me stop there and just say that I'm really interested in hearing the conversation today, and reactions, thoughts, reflections, agreements, disagreements, all welcome and appreciated. And I think at this point, Stephen, I turn it to you to moderate the rest of our discussion. Is that correct?
Correct. Thank you, David. That was a wonderful presentation. As a reminder, if you have any questions, feel free to use the Q&A or raise hand feature. Joanna, looks like you have a question. Let me allow you to talk.
Thank you. That was a wonderful talk, David. I really enjoyed it. I have a couple reaction to thinking about COVID-19 and HIV. I think one of the differences is the first of all, that we're living in a period of uncertainty. I think unlike that we've seen even in 1918, 1919 influenza epidemic, maybe similar to people who lived during World War II and suffered economically, and also all the loss of soldiers, etc. But we're living in a period where there is so much information, disinformation and misinformation. And I'm wondering, what are your thoughts about how to address this, all this stuff that's been going on generated about COVID-19? What kind of interventions are needed? What can we do about it?
Yeah, no, thanks, Joanne. I really appreciate your comments, and I think it's such an important point. And I think there's a couple of things, and it would be great to get your take and others' take on this too. Is I think we have to try and confront these areas of disinformation wherever we find them, whether it's in social media, whether it's in op-eds and so on. And I think, a couple of things I would say that maybe we could do in academia is I would sort of like to see some of the major journals have the ability for people to do op-eds that are peer-reviewed but published in like a week. And JAMA can do it. JAMA can do a fully peer-reviewed paper in 10 days or less if they think it's of sufficient importance. And I think I was just kind of looking back. I think during COVID I did maybe 10 or 12 peer-reviewed papers, but probably 15 or so op-eds in places like CNN Opinion and The Hill and so on. But Leanna Wen and Sten Vermund and I did one in JAMA where we thought that there needed to be more data forthcoming from CDC on breakthrough infections and other kinds of surveillance issues. That op-ed in JAMA, it had an additional benefit of that it was peer reviewed, even though it was an op-ed, it was peer reviewed by JAMA, but it took a little over 2 months for that to come out. And I think sometimes to confront this disinformation, we have to be able to respond in real time. And now, if you're going to respond in real time, it means social media, or doing newscasts, or it means using some of the outlets that you can do quickly, like the Hill. And I think those are very important things to do. I don't want to diminish any of those, but I think it would be really helpful if there were key parts of disinformation that, an op-ed could be peer reviewed and within 72 hours or something published in some of the key journals. So I think that's just one thing. The other is, I think there's a much longer term issue here of how will we in public health and related fields train students to be able to confront these issues. It's almost become part, it was for so long some of the key things in public health where you had to learn epidemiology and policy analysis and health communication and so on. I think now a key skill set is going to be how to identify disinformation, how to productively address it. And also related to that, I think is, people in public health are often now attacked verbally, and we have to be able to provide, I think, training to our students of how do you handle that if that happens to you. How do you address that? How do you cope with it and deal with it? And then what can policymakers do to help prevent it in the first place? So, Joanne, I think you raise a really important point. I think I've more commiserated than answered your question, but I think it's an important one. And if you or others have further comments on this, I think it's an important discussion to have.
Thank you.
Thanks, Joanne. We have a question from Lucy Leota. Oh, it's Claude. Go ahead, Claude.
Can you hear me?
Yep.
Okay, great. Thank you so much, David, for that really wonderful and meaningful talk on COVID and HIV. I just have to comment, you absolutely did justice to the giants we lost in the past week or two. Wow, I'm getting teary every time I say that, so I'll stop on that area. But really, really appreciated this. So, one area that a number of us have been focused on since COVID started for us has been the impact of the pandemic on healthcare providers and the workforce. And there are clear parallels, to the early days of HIV with so much loss, so much trauma, no vaccine, no cure, no nothing, and so much death. But now I think we have a burnt out healthcare workforce, the uncertainty that Joanne was just referring to, the disinformation in patients that makes jobs so hard that, what did the New York Times call it? The Great Resignation across the country. It's not just healthcare, but it is particular in healthcare, so that fewer people are doing more and more work. And when you're trying to create high quality, equitable healthcare systems and nurses are fleeing the field, et cetera, just any thoughts you have about directions. Clearly we have to take care of the caregiver if we're going to provide the kind of information and care that you're talking about, and just your thoughts on that and any evidence base for that and treatment going forward.
Yeah, no, those are such important points. Thank you. I think, and again, I'm probably more commiserating than answering, but I think the issue of the study of the workforce itself here at UAlbany, we have a Center for Health Workforce Studies, and over the course of COVID and even well before that, one of the things they do is put out reports looking at, in New York, for instance, how many medical, nursing, behavioral health, mental health providers are there in the state, dentists, where are they located, who are they serving, what's the demographic makeup of that healthcare workforce. And I think even more empirical work understanding that is going to be critical, because I totally agree with your point. I think I'm sort of worried about what's the net size and composition of the public health workforce look like after we have kind of the Great Resignation and the Great Investment all happening at the same time. So, we've got a lot of people leaving the field for a lot of reasons that you said, being burnt out, being abused, being just tired, not wanting to do it anymore, being underpaid, not being well treated in the system, lots of different reasons. And then, so we're losing a lot of people to the field. At the same time, there's a lot of these initiatives, like the federal government wants to hire, I believe, 100,000 more public health workers across the country. In New York, there's an initiative to have like 1,000 more public health workers. And I have to say, I can't sort of fully get a track in my mind on the math of this. If we take the Great Resignation out and then some of these major investments in, where does that leave us at the end of that in terms of the size of the workforce? But also I sort of go back to this issue of how do we develop skill sets that are going to help public health workers be as resilient as may need to be necessary in the future, as their experience is not one of necessarily receiving thanks from people in the community who are receiving services, but rather some of the verbal abuse and threats and so on. How do we help, whether it's for students or for people who further along in their careers are either coming to or kind of retooling in the public health sector, to have the coping mechanisms that are necessary to deal with that over time. And I think we've started to talk about that as a field, but I haven't seen, and I'm sure this is just my own limitation that I haven't seen it, is sort of comprehensive trainings that really help address that. And I think we're going to, that's all going to be necessary. So I think there's a lot of different aspects to this. I think there'll be a lot of people leaving the field. There'll be a lot of people joining the field. And the question is, how can they be retained over time? So anyway, those are just a few thoughts, and I'd be interested in your reactions or the reactions of others too.
Thank you. Yeah, all good points.
Thanks, Claude. Everyone, again, a reminder, if you have a question, feel free to raise your hand, or you can type the question directly into the chat.
I can make a comment. Oh, go ahead, Bob. I was gonna.
Well, yeah, I mean, I have, like you, David, I mean, I can commiserate with what we've been discussing for the last, 15 minutes. And so the pessimistic side of me, is worried about, miscommunication and disinformation and, the lack of equity and pay for workers and, the resignation that people are feeling. And that taps into my present sadness about what's going on, for us all with the losses we've experienced and having been through AIDS and all of that. But I guess the optimistic side of me is, I'm looking at our participants, and we have a lot of younger people. I do think the answers will come from the next generation. I mean, I think, when the pandemic started and we were in the early part of it, I remember saying to a lot of colleagues and friends that I think, there would be a lot of innovation that will ultimately emerge from this experience. Innovation around public health, innovation around communications, how we work and, where we work and all of that. So I do optimistically, and I would love to hear from some younger people who are here, that I think answers, I think if you look historically, innovations and generations come up with new things that some of us, will speak for myself, older folk, are like, more in the towards burnt out stage. Not yet, but, moving in that direction. That's all, just a personal comment.
I would thank you, Bob, and I would say too, and it would be great to hear from students and others who are participating today. I just quickly pay homage to our students here. The kind of innovation that you're describing, I saw a lot of, and it was really inspiring and terrific. Things like how do you deliver food to people who need it during the course of the pandemic? And we had students, I showed a picture of one student who was very interested in food security and how can you do link farm to table with need to deliver food to people who may be quarantined during the time of COVID. And it was just remarkable to bring all of those areas of sustainability and COVID and everything together. And, I certainly would not have thought of that on my own. So I think that kind of inspiration and ingenuity that you're talking about from students and others is really critical. So I agree and hope that some of the students will comment.
Claude, did you have a comment?
Yeah, can you hear me? Well, I was going in the direction that David was going, actually. I was going to ask you to maybe elaborate from where you sit on some of the systemic changes, because I do think teaching about coping and resilience and well-being and how to kind of, balance things are going to be very important. But there's clearly a need for a systemic change that you alluded to in multiple points. And so you just gave one, but are there other thoughts about what needs to happen at the care level or systems level?
Yeah, thanks, Claude. Yeah, I guess it's lots of ways to respond. I guess one way I would respond was once a month, the deans of the schools of public health across the country have a Zoom, and it's more kind of a mutual support session, kind of where we can talk about issues in different schools and programs of public health and how we're trying to address those. And just last evening we had one, and there were probably, 30 or so deans of public health on, and the topic was very much about this. It was how to create mental health programs that are supportive and wellness programs so that campuses are a place of well-being and support. And it was so interesting, the kinds of things that people brought up on that call that they were doing at a number of different public health schools. And they ranged from the very simple to the very complicated kind of. And on the more complicated end, it was making sure that standing up good quality systems of mental health and medical care that are provided, and making sure that there's access and transportation, which is incredibly important, to things like making sure that in a school, and we've just done this here at our school, having a room that's for meditation and reflection and prayer. It's non-denominational, but anyone can use it for reflection or prayer, but a place that you can go, to things like one of the persons yesterday was saying that in their school, they've had now 2 days a month are declared non-meeting days, and just giving people permission, even by Zoom. So not only no meetings in person, but no Zoom calls. Just that there'll be, every other week, there's a day that you can sort of count on that I can kind of breathe, and maybe I can write some more, or I can do some things that are important, all the way to extremely simple things like, and these are some that we've done here too, is simple gestures like we had a picnic outside that people could enjoy. We brought in apple cider donuts that people could enjoy. There's a cookie day coming up, and not that we're promoting all donuts and cookies necessarily, but the sense of community that people have now, I think there's a loss of a sense of community with COVID, and as people come back, just to be able to gather around and with appropriate masking and distancing and everything, and vaccine requirements for our students, all of that are things that people can feel a sense of place and community. And we, for shorthand, and I think this is the term that other people use a lot, but it's new to me this year, is the term placemaking. And we've thought a lot of what does it mean to us in the school to develop placemaking? And so a lot of different examples that people were talking about yesterday. And if there are examples of doing placemaking at Columbia that you'd care to share, I'd be really interested in those too. We're spending a lot of time thinking about this issue right now.
I could make a lot of comments, but I'm going to let other people have a chance. Thank you.
Thanks, Claude.
I might write you separately.
Please do, please. And I just wanted to say too to the group today, my email is dholtgrave@albany.edu. Just dholtgrave@albany.edu. I'd love to stay in touch. Please do.
Phil, did you have a question or comment?
Yeah, thanks, Stephen. Really excellent talk. Thank you so much. I'm Phil Krasinski. I just wanted to circle back to a comment, make another comment, and add a question to what Joanne raised, that potentially a difference between the current moment versus when HIV emerged is the ways that we communicate, and thinking about how misinformation travels, and that push us to think about these social networks as systems, just like healthcare systems or other systems like where we work, our offices, but these are networks created by people that allow for certain types of information to move in certain ways. And even pre-COVID, there were a couple of papers in Science in 2018 showing, and we all have heard this probably now many times, but that misinformation travels faster than the truth. And that's actually, people have been saying that since the telegraph. But I guess I would wonder about your perspective on what do you think the role is of people in public health? And then there's also information, there's studies that show that, we can modify these systems to reduce the spread of disinformation, like by putting fact-based stories in related stories when there's a misinformation posted. So what do you think our role is as public health researchers, and thinking about the comment that I think it was Faggy made, the line between activism, but what is our role in terms of influencing how these private sector structures are formed and really make money off of the spread of misinformation, and how might we be able to influence the change in these types of systems?
Yeah, I happy to share a couple of ideas, Phil, and you've done more work in this space than I have, so I'd love to hear your thoughts and comments as well. I think maybe one way to answer this is to sort of kind of share some of my own evolution kind of during the time of COVID. I think it did more in the way of social media to try and I tried sort of not to, mainly in Twitter, I would say, and whether this was a good or a bad idea, I don't know, but not so much to directly get into arguments or something. I don't know what the right noun is, but rather to kind of be bringing forward data and to be trying to fill the space more with evidence-based findings or policies or programs or studies that were coming out or things that we did. Also, as I was mentioning earlier, I found myself, I felt like it was useful to do more in the way of op-ed writing in real time. And it goes back to this issue of, I kind of like to see some of our main journals have an opportunity where you could have something in some of these key journals as fast as you could in a major newspaper or in CNN Opinion or something like that. I thought it was important to sort of comment in real time on some things that needed to be addressed and to sort of summarize the data. And one of the things I tried to do was in some of those op-eds, you don't have a reference section, of course, but you can hyperlink to things. And most of my op-eds are just hyperlinked to all imagination. There'll be 3 and 4 hyperlinks in one sentence, because I wanted to make sure that I was making the point that the assertions had some foundation as well, too. And then, I think in terms of public health overall, I think one of the things that's important for us, and this has come up with the Association of Schools and Programs of Public Health, is we certainly did have some public health voices in the media, but certainly in COVID, there were more medical voices in the media. And again, I have great colleagues in medicine. That's not a criticism of medicine at all, but rather to say there also needed to be more voices from public health. And I think also more voices from behavioral social science and communication science as well. Because at the end of the day, a lot of COVID, we were really talking about things like social distancing and mask wearing and so on, kind of pre-vaccines. And a lot of that was about principles that we all know around social and behavioral and communication science. but it was rare to see somebody with that kind of background in a major media outlet talking about some of those issues. So anyway, those I think those are a few thoughts that I would raise, Phil, but I'd be really seriously interested in your thoughts about this further as well, too.
Great. Yeah, thank you. I guess the one piece I would just still be curious about is, like, for example, like your Twitter account could be like amplified versus some unknown, like doctor, you know, unverified doctor or something. But I hear what you're saying about the steps you did take, and that makes sense.
Well, and just thank you, Phil. And just to your point, I'm still no blue check mark in Twitter, and it's fascinating, this whole issue of the blue check marks in Twitter and what goes into this verification. And there's many very credible voices that I think are not verified, and I'm not sure that always verification means that that's a source that everyone should necessarily listen to. So I'm just thank you, and I just reacting to the verification issue that is ongoing in Twitter. But and Stephen, I think my old friend John Santelli had his hand up earlier as well.
Correct, John. Feel free to unmute yourself.
David, so nice to see you and hear you today. And I have fond memories of our time together at CDC, and so great and welcome, and a wonderful conceptualization of how the science around this new pandemic can build upon everything we learned from HIV. I mean, you and I were at CDC when they discovered behavioral science, yeah. Which is scary. But anyway, but no, it was a good thing. It was sad that it took it so long. But so all of the lessons we learned from HIV, behavioral science, social determinants, working with communities, dealing with mental health issues. I mean, as Claude was mentioning, are really essential as we look at this new pandemic. And so as somebody that's doing a lot more teaching than I used to, I think that vision of science is actually really essential, because public health folks, masters, need to leave with an MPH where they clearly do understand that science is not just a randomized clinical trial, but it's the dissemination. It's everything you talked about. So thank you. I think that's very useful, and I think it'll be very useful in your new role and my new role as educators. But I also would like to pick up on what Joanne and Bob and just about everybody has mentioned, is this rejection of science. I mean, it was very apparent that went on throughout the epidemic. You know, CDC never endorsed, harm reduction, particularly, needle exchange, at least not in our memory, in our time at CDC. And we had vaccine rejection in pediatrics well before we had a COVID vaccine. But, what insights do you, I want to push you on this, because I think, what insights do we have from everything we learned about HIV, about getting people to focus on that broad view of science? But when we're confronting people who are, from our point of view, almost seem nuts, right? I mean, they seem like deranged, but they're not. I mean, they're citizens, I guess.
Yeah, no, thanks, John. And it's so great to be back in touch with you. And I remember our days at CDC similarly as well, too. So terrific to be talking with you today. And I think you raise a really interesting point. I mean, I guess in some ways, a couple of things. I mean, one, I sort of go back to even in HIV, the science wasn't necessarily always going to win the day, but without it, you were sort of doomed, I guess I would say, in that, as you were talking about the early examples of syringe exchange programs sort of in the 90s, we could do evaluations and we could talk about the science, but we couldn't purchase syringes and we couldn't have demonstration projects for syringe programs. But the talking about the science was maybe not going to be enough. But if you didn't have the science assembled and articulated in a way that it could be readily communicated, you knew you were sort of doomed, because then somebody could easily say, oh, well, you don't know whether this works or whatever.
Yeah.
At least if you had the science, it was useful. I think it was often, in just an elaboration on that point, I think reminded me too, like when we would go roughly every year or so to see OMB in the Examiner about the HIV program at CDC, the three questions, and you know this as well or better than I do, John, was always how do you spend your money, how do you know it's effective, and how do you know it's cost effective? And if you couldn't answer those three questions, you were kind of stalled in terms of trying to expand the programs. If you could answer those three questions, you might not necessarily get an expansion of the program, but at least you sort of move beyond that as the array of is the barrier. So I think that's one issue. I guess the other thing is, I wonder if we have to think about what our time frame is, and I want our time frame to be instant. So I say that saying I hope this is not necessarily the case, but some of the things that you were reflecting on, like syringe exchange programs, just now in the Biden-Harris first year statement of priorities around substance use in the U.S. is the first time an administration has used harm reduction in a document. So I think, you and I were just now reflecting on things from, what was it, 97, 98, maybe, or so on, more than 3 decades ago. And that's a very long time horizon to go from that to now we can say harm reduction in a presidential or an administration document. And I hope it doesn't take that long in COVID and other areas, and we can find ways to shorten this. But thinking about what was that time horizon and how could we have shortened it in some way. And I'm also mindful that I know we're right up on 11, but I hope, John, we can continue this conversation at some other point. I'd like to further have this chat with you, if you don't mind.
That'd be fun, David. Yeah. I'm glad you're nearby. I didn't realize you were. That's great.
Thanks, John.
Well, yeah, thank you. We can't thank you enough, David, for being here, for gracing us with your presence, for your perspective, your wisdom, and your collegiality. It's very special to many of us, as you know. And we wish everyone a special and blessed Thanksgiving with family and friends during these very challenging times for all of us. So be well, and we'll see you all in December.